Okay, hello. Today we are presenting our PDSA project. It is about fall prevention. My name is Jill Tomopoulos. Each of us will introduce ourselves when we speak. So I'm going to start us off. And then here is the overview of what we'll be discussing with our names in each slide. So to begin with, I like to discuss the significance about falls. Even though it's been decreasing over the past several years, it still remains a significant problem in hospitals. Roughly about 700,000 to 1 million patients fall in the US alone, and it results in 250,000 injuries, while 11,000 of them lead to deaths. Falls in hospitals can result in significant burdens to not only the patient, but to hospitals as well. For example, Medicare, Medicaid services stopped reimbursing hospitals for fall related injuries. Um, Falls are still a problem despite our assessments and interventions of fall risk patients. So, we believe with our PDSA project, we are researching on how falls can be decreased and prevented within each of our units. So, to identify the issue, what is considered a fall? A fall is an event that results in a person coming to a rest on the ground or other lower level unintentionally, which is not as a result of a major intrinsic event, such as a stroke or overwhelming hazard. Some risk factors for falls, there's both intrinsic and extrinsic. For intrinsic, this includes age, gender, musculoskeletal disorders, patient imbalance, use of medication, visual impairment, health conditions, and history of falls. For extrinsic, this also includes the length of hospital stays, the design of medical equipment, communication within the healthcare team, um, and training and the use of mobility aids. With that, the rate of falls depends on the hospital and unit type. So, for example, some units, such as like the neuro ICU, will receive more fall risk patients than your typical med-surg unit. With that, fall rates range from 2.6 to 7 per 1,000 patients day. Almost 23% to 42% contribute to one type of injury, and 2% to 9% lead to serious injuries. Patients are disposed to mental harm such as increased anxiety, fear of falling, and loss of self-confidence. The first step in preventing falls is identifying high-risk patients and selecting effective measures for fall prevention.
Hi, I'm Sarah. So I'm going to present the quality variance, both the standard and the results together. So in 2020, it was found that fall rates were at an all-time high, especially among male patients that were 65 years and older. Specifically, it was found that roughly 70% of men who were 65 years and older fell, actually resulted in death in comparison to women, which was about 61%. Nearly 1/3 of annual falls are preventable. So the AHRQ created a fall prevention toolkit in 2015 that was meant to kind of address the issue amongst patients in an acute setting and an outpatient setting. This toolkit was designed with the consideration of like challenges associated with designing and implementing a fall prevention program nationwide. The toolkit was implemented from 2015 to 2018 in facilities across Boston and New York. Over 37,000 patients were involved in this or using this toolkit essentially on their units. The hope was that by implementing this toolkit, not only would patient falls be reduced, but the length of their hospitalization, mortality, and just medical associated costs would also decrease. Next slide. So this is the evidence portion. While the AHRQ did not specifically quantify the percentage in which they hope to reduce falls, their vision was to introduce and implement a solution that would reduce patient injury. Based on the units that adopted this toolkit, it was noted that inpatient falls were reduced by over 15%, and falls would have prolonged and the basically by implementing this toolkit, not only were the falls reduced by 15%, but also falls that included prolonging hospital stays and increased medical costs were also decreased by over 34%. Unfortunately, the CDC has highlighted that one of the leading causes of death among elderly people is the injuries they sustain from the falls. In fact, in 2021, for every 100,000 patients, roughly 78 of them died from falls versus in 2012, 55 for every 100,000 patients died in 2021. So basically, in other words, this was an alarming increase of over 41% in less than 10 years. The facilities in which we did our project research require that for every fall that is sustained on the units, a variance report is filed at the end of the shift. Patients are assessed thoroughly at admission and each shift to determine what kind of measures need to be taken to prevent a fall. Reorienting patient is usually done as much as possible, but if that doesn't work, the policy states that patients must have a sitter at the bedside.
Okay, it's me talking again, Jill Demopoulos. I'll be discussing the root cause analysis. Um, so, why do falls happen? So, a lack of patient-centered practice, congruence, and organization focus have caused and continue to cause the preventable patient injury or death while increasing costs of care. Leads to falls. Closing the performance gap within an organizational focus will require leaders and their healthcare systems to commit to specific actions by all disciplines to the organization in partnership with the patients at risk as well as family. With that, with our routine care, we need to consider reassessing fall risk in the presence of risk factors every shift, provide education for patient and family, use ambulation equipment and visual cues, tailor interventions to specific fall risk factors, keep beds at the most appropriate height for the patient, use a gait belt upon ambulation unless contraindicated, ask patient to understand and accept that they are at risk for falls. Ensure to have the non-skid fitted footwear and do not use restraints just to prevent falls. Any disruptions in routine care can increase the event of falls. In terms of improvement, we need to close the gap. So we should consider nurse assistants responsive to call lights. So we need to consider equipment environmental risks, such as the rails not being up. We need to consider the patient is not being mobilized hourly. There may be some bias for some patients, such as ageism. The floor may be too glossy and the windows can create a glare on the floor, so it affects the sight of the floor that the patient's walking on. There may be a lack of handrails in the rooms in the hall or in the hallways. There may be changes in the patient's treatment or medication. And there may be a lack of sensitivity to fall risk factors for those of different backgrounds, like those who need to wash their feet before praying.
Hi, my name is Justine Miranda, and I'm going to be presenting the scope of the problem. So for falls, although CMS has classified falls as a never event, it has become a common event that 2.3 to 7 falls per 1,000 patients occur in inpatient hospital settings. Studies show that the cause of most falls include patients with limited mobility, altered mental status, advanced age, and sensory deficits. Hospitalized patients are at increased risk for falls, which can result in serious injuries such as hip fractures, subdural hematomas, and in extreme cases can result in death. Falls that result in injuries can extend a patient's stay, and costs can range from about $19,000 to $32,000. So the stakeholders that are affected in falls are the patient and the patient's family as well. fall prevention champions, the healthcare team members such as nurses, physicians, physical therapists, occupational therapists, institutional leaders, funding agency, and insurance agencies. Next slide, please. So the solution. So unfortunately, a solution that or reason why falls mostly happen is because of the staffing situation. Unfortunately, that is not something that we can control. But what we can do is doing our fall risk assessments every shift. What I found on my unit was a lot of the times our nurses did not know how to accurately assess patients for falls. So re-education on what actually makes a patient a fall risk needs to be done, using the Morse fall risk assessment scale. Fall risk signage and verbiage should always be visibly displayed for all staff to see. A yellow fall kit can be used that includes non-slip socks in the kit, which should be yellow. There should be a yellow wristband in the kit as well. A yellow blanket that should be displayed on the patient's bed so that any nurse passing by the rooms can see visibly that that patient is a fall risk. And all of these kits should be given to patients that have been deemed a fall risks through after assessment. Bed should always be set at the lowest position. Call light always be within reach, with the patient teaching back on how to use the call light. The bed alarms for fall risk patients should be in place, connected, making sure that it's working. The patient equipment, such as walkers, bedside commodes, canes, they should always be at close reach to the patient. The room should be free of clutter, and the implementation of no pass zones should be done. No pass zones are basically anywhere that there is a patient. If there's a call light going off, a bed alarm going off, and it doesn't matter what staff is passing by. It could be EVS, it could be a manager, it could be a doctor, anybody that is passing by and they see that call light going off should answer it and then let the appropriate person know that that call light needs to be answered immediately. So I actually did implement this after this was implemented on my unit. We were about, I want to say 22 days without a fall after this was implemented. Okay, that's it. Thank you.
Okay, my name is Dana. I'm going to talk about how do we implement fall prevention program. According to the Agency for Healthcare Research and Quality, we need an implementation team, a unit team, and unit fall champions. So what are the staff roles? Fall prevention implementation team roles and training involve and assist staff in customizing practices according to the type of the unit and the patient population. In collaboration with employees, supervisor, and other clinicians, the team leads, organizes, and support changes. Staff must be involved in identifying problems and testing solutions. The unit team ensures that the care is given and documented, conducts fall risk assessments at admission and at the beginning of each shift, also provides training for the full staff and monitors the temporary staff, and integrates the fall risk assessment and data into the shift handoff. Also, they clearly define each team member's role. The unit champions ensure assistance for the staff. They should involve aides like nursing assistants to help the bedside nurses. The more champions on the unit, the better, but at least once shift, it's ideal. To maintain patient safety, they can perform hourly rounding and regular environmental rounds as well. Fall champions should be knowledgeable and also have the ability to work with all key stakeholders. Also, they need to serve as a liaison among teams and to track injuries and close calls, and conduct audits. They also need to train the peers, the patient, and their families. Next. For the analysis, in the facilities, we did our project. The patients were assessed thoroughly each shift, and information was passed during handoff. All staff was trained on fall measures, and extra help was called in when needed, for example, sitters. If a fall happened, the various report was filed and a debrief meeting was held. To sum up, in order to successfully implement the fall prevention program, there's a need to train the staff and provide education opportunities on a regular basis and as needed, post updates and outcomes on the fall measures, collect data and monitor fall rates and prevention practices, review literature and the new best practices. Also provide feedback on the prevention strategies and celebrate the success. Next.
Hi, this is Sarah Chai again. So I'm going to talk about the next steps. So some of the next steps after, solution implementation and, analysis of those is considering staying current on the latest fall prevention methods and measures as required at both the federal and state level, adopting and utilizing the latest technology. So that includes video monitoring, patient sensors, and even robotics. Some other steps to consider is strict documentation of the falls that occur on the unit. Like Dana was saying, that after a fall, a variance report is filed and debriefing is done. Continuously monitoring patients and assessing their risk based on data that is documented. Providing in-service on unit education for all staff members for the latest fall prevention measures. By what I mean by in-service is that, like, at my facility, when we need to do like an education moment, we have managers on the floor. They usually will call a specialist in, or someone will come in, and basically all the staff that's on the floor, what they mean by in-service is that we attend like an educational like moment essentially, and someone is teaching us for whatever reason. Like, I know this is unrelated, but for example, like with beds and like Hoover mats, we have a lot of new grads that just came to my facility, so some of them don't know how to operate that. So by in-service, someone will come in and they will teach everyone on the floor how to do that. So it's kind of the same idea for fall prevention methods. Implementing quarterly and as needed unit meetings to discuss fall prevention measures and to determine like actual progress that's happening. So like what Justine was saying, how like by implementing her fall interventions, like she was able to a fall on her unit for like 22 days and so that kind of idea. And then, of course, reminding staff to assess and document and monitor patient falls on admission and also at the beginning of every single shift.
All right, and that is the end of our presentation. Here's our references, and thank you for watching.